Good afternoon, everyone. Thank you for joining us today for Aspire to Knock Out Pneumonia Readmissions webinar series number 8, Action Plan Implementation, Report Out, and Next Steps. We'd like this meeting to be very interactive, so we're anticipating that you will be highly engaged in today's session. We encourage you to ask questions and share information throughout the webinar today utilizing the chat panel. We will keep all lines muted to cut down on feedback, distractions, and echoing. Before we get started, I'd like to go over the logistics for today's session. As mentioned before, all lines are currently muted and in listen-only mode. Please chat with your colleagues, hosts, and panelists throughout the webinar today utilizing the chat panel. You can find it by clicking on the chat bubble in the bottom center left of your control panel. Please make sure your to setting is set to all panelists and attendees. This session is being recorded and will be made available on the NCHA website and through email notifications shortly after the conclusion of today's session. Facilitating for you today is Trish Vandersee, Program Director of Quality and Clinical Performance Improvement of the NC Healthcare Association. And presenting for you today is Dr. Amy Boutwell, Founder of the Collaborative Healthcare Strategies. At this time, I'd like to turn the presentation over to Dr. Boutwell.
Great, thank you, Sarah, and welcome everyone. Sarah, can you hear me okay?
Yes, I can.
Okay, excellent. Thank you so much. I had a little echo there. Okay. Welcome everyone. Sorry for my distraction here getting started with the echo, but it sounds a little bit better now, so I appreciate it. So welcome to the final webinar of the Knock Out Pneumonia Readmission series. This is a very special day. Work that we have done together over the past year, and the information that we have shared through this series, and I'm so appreciative to the North Carolina Hospital Association and Foundation for supporting this work that has been really so robust and active throughout the entire year. So looking back on what we have covered and what we have done together, this has been the curriculum. In fact, not only the past year, but really over the past 9 months of just a lot of content-rich information to support your readmission reduction work, and more specifically, your work to reduce pneumonia readmissions. Hopefully, you will come back to this slide as you move forward from this series, and you'll be able to see here the elements of, if you will, the curriculum. This is the Aspire curriculum, and you will be able to use the slides, the webinar series, and the slide decks, as well as the playbook for ongoing need-to-know, just-in-time information. The Aspire guide is very rich and robust with a lot of information, and of course, one thing that we've done with you in this series is to break it down into digestible components. So again, today what we'd like to do is follow up on some of the discussion that we had in the in-person workshop in November. It was a great group that gathered. I was so appreciative to everybody who participated so well in the session. We really got into some nuts and bolts, and so we'll reflect on some of the key points and also some of the action steps that came out of that workshop. This is just a reminder of the Aspire guide. When we say we've been going through the Aspire curriculum, I know that some of you come onto these calls new, or you haven't been on all of them. So what you can see here on the left-hand side of the background of the screen is the book, really, the guide, the physical copy. It's about a 85-page document, the Aspire guide, and the core content and the strategy of reducing pneumonia readmissions or reducing any readmissions has been laid out here in the driver diagram, which you can see corresponds with that Aspire acronym. That's the material that we've been going through together over the past year. So the objectives for today are learn what you're doing as a result of the Knockout Pneumonia Readmission webinar series and support series, and get ideas from each other around your feasible, meaningful next steps. I always like to especially end the year, end a program looking forward, not on what you're doing or what you have done, but rather what are you taking with you into the future, and of course celebrate a great year together as we wrap up here today. So let's reflect a little bit on the in-person working session. Now, I had the opportunity to quickly look over the registration list today and to look over some of the names here that have joined us today. And what I would really like to know, and I'm hoping that many of you are on the Zoom platform and you can find that chat box. If you hover to the top of your screen, this is the challenging thing that I realize about finding the chat. You got to go up to the top of the screen. At least on my view, you need to go over to the More button and then find the chat. So if you're having difficulty finding chat, just keep looking around and look in that More button if you haven't found it. But this will be really helpful for me to know, because really what I want to do today is I want to go over information that we covered at the in-person working session. But by all means, if most of you were at the in-person session, then what I would rather do is talk to you about what you're doing, what your takeaways were, what your next steps are, and how, and problem solve anything that has come up in the month since we were together. So really the in-person working session, the main themes of the day were linking the priorities around reducing readmissions to the design of what it is that we're doing every day. Number two was learning from a variety of successes. There are so many ways to successfully reduce readmissions. Sometimes people say that there's no more progress to be made, or that we've leveled out, and that is just absolutely not my experience in the field. There is so much success. There are so many pathways to success, and we covered a lot of those in the in-person session through sharing of videos of real-world teams applying to get the success that they will. We took those ideas, needed ideas that would be feasible, high impact to you in your organization in order to achieve your aims. And teams came away with 7-day next steps, 7-day action plans for next steps, and 30-day action plans to really dig in and make some progress month to month. And that's really how we do it in readmission reduction work. We make progress week to week and month to month. But if we're not trying to make progress on a week-to-week or month-to-month basis, then I promise you, you're probably not making progress at all, because it's that kind of a pace and an attention to daily operations that really get us the results that we're trying to get. At the in-person session in particular, we shared the Knockout Pneumonia Readmission Playbook. And this is a resource that has been emailed to many of you. Those of you at the session, you had it in your packets. It's also available on the website, the NCHA Knockout Pneumonia Readmissions website. But what I just wanted to do is really highlight something that is very, I would say, rather unique about this playbook. And the reason why we call it the playbook is, as I said, the Aspire Guide is 80 some odd pages long, and this webinar series, we've done 8 webinars. That's 8 hours of content that you have to access. But I know you're busy. You are busy, and you're going from meeting to meeting, and you've got to go. You've got to make decisions. You've got to get information in easily digestible chunks. So what we've done is we've boiled down the core concepts to 1 page per concept. And I personally, as someone, of course, I wrote the Aspire Guide, but I really like how this turned out for you, in the sense that this is skimmable. You can take 1 page to your next meeting. You can read 1 page before you facilitate your next meeting. I think this is very need to know, timely, easily skimmable, digestible information that still gets you to the key points without having to wade through a lot of resources. That said, so you'll see that this playbook is 10 pages long. That's it. And then all of the resources that we have referenced and drawn from and created in the Knockout Pneumonia Readmission series is here on the last page, which would be obviously all of the webinars with the slides, the Aspire toolkit, and the other webinar series I did for the Agency for Healthcare Research and Quality, which is not the same, and then a link to some short videos that I've done for the American Hospital Association that again just delivers the content in different ways. So hopefully you feel, I know that the participants in the in-person workshop really resonated with these key concepts of know your data, make sure you are addressing and understanding root causes, and design services that address those root causes. They're not just, it's not about what we think is the right medical or nursing answer, but what we really need to do is develop strategies that are actually going to help our patients stay out of the hospital. So just a quick screenshot of basically the 6 pages going through 6 Aspire strategies. You can skim the titles yourself, but you can see how we've kind of boiled it down to core concepts, key recommendations, and then references and links for more information. So I really do hope that you'll pull this out of your files and circulate it within your readmission teams and within your readmission committees. Many of you are linked to the rest of the readmission work going on at your hospital. So this would be something that I think you could feel comfortable circulating with your broader readmission committee members. So let's just cover a couple things. And again, I'm keeping my eye on the chat box and would encourage you to keep this interactive and talk about any of your thoughts with regard to this topic. But at the in-person session, we talked about kind of broadly speaking, what are the priorities of the organization and what is it that you're doing? And are they linked? So we really kind of broke down what's the organization, usually the hospital's motivation to reduce readmissions? What's your aim statement? How does that relate to your target population that you're focused on and the interventions that you're implementing? The burning issues kind of that we got on the table during the workshop were the following. Teams really wanted to better understand and figure out a better way to identify the root causes of readmissions. Lots of teams wanted to talk about and address readmissions from the skilled nursing environment, how to mobilize and deploy resources for transitional care, hospital and home care partnerships, readmission and the relationship between readmission and length of stay. There was an interesting quick conversation about thinking that as length of stay has gone down and readmissions have gone up, maybe we should just ought to keep people a little bit longer in the hospital. And, I'm sure the data out there is mixed, but it happens to be that a study had just come out the day before demonstrating that every additional day of length of stay actually conferred an increased readmission risk. And so, so it's not as simple as if we keep them for one more day, they'll be tuned up, in good shape, their social and behavioral issues and their transportation, logistical, and financial issues will be solved, right? We know, of course, that's not the case, such that the relationship between readmission and length of stay is at best unclear, but it's not necessarily the case that that keeping people longer is a readmission reduction strategy. Teams wanted to talk about how do we not only make post-discharge appointments in a timely manner, who does it, and how does that get done, but how the heck do you facilitate the process of people actually going to their post-discharge appointments? Because it's one thing, of course, to make the appointments, it's another thing to have that effort help us actually reduce readmissions. And so that again brings us back to root causes, and are we designing interventions and putting our efforts into the areas that are going to help reduce readmission? And then good discussion about the challenge of even that broad term medication reconciliation and really boiling it down to the fact that what we really need is a living document that's accurate. And it's going to change, and we have to expect that it's going to change, but it needs to be accurate, and how can we ensure the accuracy of that? And so these were some really great burning issues, and it would be great, again, if you're in front of your chat, if you wanted to let us know what some of your burning issues with regard to reducing readmissions or pneumonia readmissions are. We then moved into connecting the dots between why is your, and it was mostly hospitals, but I don't want to forget that we had some group practices and some skilled nursing facilities and some accountable care organizations, but I'm going to say hospital because it's just easier. So what's your hospital's motivation to reduce readmission? And it spans the gamut. And so if you, so it's really important if you are leading an effort or participating in an effort to reduce readmissions, is the mandate get us out of the penalty zone? Is it a bit more commonly, it's actually about the value-based purchasing incentive program, or maybe it's connected to HCAHPS scores, or the overarching priority from the executive team or the board might be, let's get those star ratings up. Many times we still see that whatever the commercial plans are asking us to do is really taking a lot of our attention, even if it's a small minority of readmissions, but that's a reality. And so is that the reality at your hospital? And then a couple, I think there was one or two hospitals that said really reducing readmissions helps us with our throughput and capacity problem because we are at diversion and we really want to free up beds for sick people in our community, which is, again, a very wonderful motivation, somewhat less common. So why is this important? It's important to know what is the driving priority and motivation of the hospital, of your organization, to reduce readmissions, because if I just go and talk to you about reducing all-cause readmissions, Medicaid readmissions, or some flavor of readmissions, but that's not really what your leadership is focused on, then all the content in the world is not going to help you solve your problem or achieve the aim that you're being asked to achieve. So really getting specific about what's the priority and then what's the aim statement. Now look at some of these aim statements that we kind of harvested from the discussion. These are good aim statements. So let's take a quick look. One team was charged with reducing all-cause, all-payer pneumonia readmissions by 7.5% this year. Excuse me, just get that out. Okay. Another team was charged with reducing all-cause readmissions across the board from 0.9 to 0.8 by the end of this year. Another team reduced all-cause readmissions to 11% by next June, the end of that fiscal year. So here's just a couple obvious things. In the Knockout Pneumonia Readmission Series, what brought us together, of course, was high pneumonia mortality in North Carolina, and along with that, relatively high magnitude of readmission penalties for pneumonia from Medicare in North Carolina. And so those two things went together. Some teams are focused on pneumonia readmission. Most teams are focused on reduce all-cause readmissions, but there is a discrepancy sometimes between the motivation, the aim statement, and what I'm going to show you next, which is the target population. So if we want to reduce all-cause, all-payer pneumonia readmissions, for example, you've already decided, and this is key, so I hope you'll pay attention here. You've already decided that your pneumonia readmission rates are high. Now, back at the beginning of the Knockout Pneumonia Readmission Series, Trish and I and the NCHA analytic team, we gave you all these hospital reports. And one thing I remember from the hospital pneumonia readmission reports is that, you know, whether you're the smallest hospital or the largest hospital, in general, we've got like 0 to 15 pneumonia discharges a day. But it's not that much, you know, whether it's 0, 1, or 2, or whether it's 15-ish, that's still not that many discharges a day. So as I've come to you know, not only get to know your work a little bit, but, you know, see thousands of teams across the United States, if you're focused on a disease-specific population, like we are going to knock out pneumonia readmissions, then you've decided that your pneumonia readmission rate is too high. Okay, right? That you're following me. It's too high. But teams are then stratifying within pneumonia who is high risk or who's not high risk, or you're deploying your intervention based on patients going home or to SNFs, but you're segmenting a target population that you've already defined in whole as high risk, meaning all pneumonia patients, if you have a high pneumonia readmission rate, then all pneumonia patients should be your target population, not, quote, high-risk pneumonia patients, not pneumonia patients going home. So that is one of my key takeaways from the Knockout Pneumonia Readmission series for you to really think about. Why, if you're not serving all of your pneumonia patients with transitional care, whatever that is, you know, phone calls, a med rec, warm handoffs, but what you should be doing is, if you've decided that you're focused on reducing pneumonia readmissions, then please think about my recommendation to serve all pneumonia discharges and not to further subsegment. We segment a population when we're looking for high risk, but if you've defined a disease-specific population as high risk, don't further segment it. Hopefully that makes sense. If you have questions, this is a good time to chat them in. So then we look at the other two aim statements. The other two aim statements are reduce all-cause readmissions. Now we're going to move to the target populations. If your goal is to reduce all-cause readmissions, which is my most favorite goal, then what we want is we want a target population that is defined as the highest risk target population at the hospital, because then mathematically we're giving ourselves the best chance readmissions if we reduce the highest, the readmissions in the highest risk groups. So here are some of the target populations, again, that the good people who were at the workshop offered forth as their target populations. So number one, we've got the classics, right? The classics, COPD, heart failure, AMI, and pneumonia. Though that is obviously a target population that is born of what priority? The priority to reduce Medicare readmission penalties. Whenever and I hope you're following me in terms of the logic here, motivation, aim statement, target population. These are all logically linked together. So when a team tells me the target population is AMI, heart failure, pneumonia, and COPD, I say, oh, your motivation is to reduce Medicare penalties. But some teams say, oh no, our motivation is to reduce all-cause readmissions across the board, Medicare, Medicaid, and commercial. To which I'll say, there's a disconnect between your target population and your motivation, because the penalty diagnoses are not the target population that is leading to the most readmissions at your hospital. The most readmissions at your hospital are being generated at minimum by your sepsis patients. And thankfully, we had some teams at the workshop that were focused on sepsis, because we've come to an awakening in the past year around the fact that sepsis is the primary discharge that leads to the most readmissions, not the highest readmission rate, but rather the most readmissions in the country, in Medicare, and probably at your hospital. So then we've got kind of some other special populations, UTI, sickle cell, uninsured, and then a very, very common target population, we are focusing on patients identified as high risk by EPIC, Cerner, Javion, or the LACE score or the modified LACE score. And so that is, obviously that's increasingly common out there. And the most important thing I can say about this is if you are implementing a program based on serving patients who have a high risk score on any of these, any tool, high risk on any tool, then I always say, and how many discharges per day is that? How many discharges per month was that? And what is the readmission rate of that population? Sadly and usually, teams can't answer that question. So we're accustomed to measuring, in heart failure, for example, we're accustomed to saying, last month we had, 28 heart failure discharges, and then, whatever, 8 of them were readmitted. What you want to do is apply the same tracking and analytics to the high risk score. Oftentimes, at least I know for me in EPIC, somebody might have a quote high risk score over there on the banner on the EPIC score, but that is present only for the admission, and then it's extinguished. You see what I'm saying? So you need to make sure that if you are using an EMR or something like that, high risk score, that you are saying, okay, these 10 discharges today were identified as high risk. We're now taking the next step to intervene on them, and then we are going to measure the readmission rate, just exactly as if you were running a COPD, heart failure, AMI, pneumonia program. And then some of you have taken up the enthusiasm that I'm in on the multi-visit patients, MVPs that we used to call high utilizers. So you can see even across this small group of folks, relatively small group of folks gathered at the workshop, we've got we've got kind of a wide variety of motivations for reducing readmissions, a rather, I would say, a rather minimal variety around the aim statements, but then that has a lot of variety on the target populations. So as you think about this main point I'm trying to make, part of the success that I've seen teams have is when you know what you're doing and that corresponds to your specific aim statement, and that corresponds to your specific target population. And so make sure that you're coming out of the Aspire series here saying, if we're working on reducing pneumonia readmissions, then we should be focused on all pneumonia patients. If we're working on reducing all-cause hospital-wide readmissions, then we should be focusing on the highest risk populations across the hospital. And that's probably not, well, I'm telling you, it's not limited to the Medicare penalty diagnoses of COPD, heart failure, AMI, pneumonia, et cetera. It would definitely include sepsis, behavioral health, for some of you sickle cell, and for everybody multi-visit patients. So that would be my signal that you've done the data analysis. If you're trying to reduce all-cause readmissions, it's those other target populations that would say, yes, this is a team who's done their data analysis and they are actually working on the target populations that are causing the most readmissions to their hospital. Thus, I have confidence that they are targeting correctly. And now let's move on to what interventions they're doing. Are the interventions matched to the root causes for those target populations? So takeaways, you can ask yourself now and at your next meeting, does your organization's motivation to reduce readmissions align with your organization's aim statements? Does your target population criteria align with your readmission reduction aim statement as well? So we then shared a bunch of videos, and I'm sharing them now we won't watch the videos, but I'm sharing the links with you now because the videos really conveyed a lot of incredibly relevant information coming from the field, coming from hospital teams just like yours from across the country, We're all really doing the same work. And one thing that, again, I hope that you'll remember from what I've shared with you in this webinar series is, and what my unique perspective is on reducing readmissions is that we are much, much more similar than we are dissimilar. And there are very few hospitals that, quote, have resources. And we're kind of all feeling like we operate, quote, without enough resources. And so part of what I have come to learn over a decade of doing this work all day, every day across the country is we are all executing change management within the confines and constructs of our limited resources. And yet success is still possible. And that is a key takeaway. So I keep meeting teams across the country and, and including across North Carolina, where the first order is we can't reduce readmissions because we just don't have resources like other places have. And I just hope that you will look at these videos and you will really kind of abstract whatever they did in California or Arizona or Virginia or wherever the case may be and say to yourself, these teams also said, we don't have enough resources. And yet, this is what they did with what they had. And that's, I think, really a key insight that someone who works, literally in every state and across and been exposed to 1,000 hospitals, that's what I can bring to you so you can remind yourself, we can have success. What we're doing is change management within the context of what we have available to us. So a reminder here, and you might, come back to this slide in your meetings, and as you remind yourself on, change management within context is what I just spent a lot of time on was talking about the design. Knowing your data, knowing your motivation, designing your target defining your target population based on your data in a way that will achieve your aim. And then we want to know what is available to us in the community from within the hospital, across the medical system, whether that's bundled payments or ACOs or patient-centered medical homes or CCNC or whatever the case may be, survey what's going on, and then based on the context of your own resources, design a multifaceted portfolio of strategies that can actually get you results within the construct of what you already have, to play with, if you will, to leverage, to work with. So come back to the driver diagram that defines the Aspire methodology. And then as we covered in our October webinar, really what's not in the Aspire guide but has come from all the implementation experience of implementing Aspire is the importance of executing and driving up service delivery and having a whole person approach and collaborating across the continuum and maintaining an operational dashboard. So this is the 3-part operational dashboard that I really encourage people to focus on. If you focus on nothing else, focus on these 3 things, and test for yourself. Maybe you like 2 of the 3 things. That's fine. I say number 1 is close the gap. Whatever your target population is, if that's pneumonia readmissions, if it's Medicare penalty discharge diagnoses, if it's high risk on Javion, the top purple line is how many discharges did you have this month that met your target population criteria. If you can't answer that, then I'm pretty sure that if I met you, I would say you're not likely to get your readmission reduction results. At minimum, you need to know your purple line. How many discharges per month are in your target population? And you want to look at that every month. And then what you want to do is in that lower pinkish line is how many did we serve? And this is the key. Trying doesn't count. The only thing you measure is actual service delivery. If we intended to, do a warm handoff, did we do it? if we intended to do a post-discharge follow-up phone call within 2 to 3 days of discharge, did we do it? Not did we try. A lot of us count trying. I want you to focus on execution. Did we do it? And what we want to do is close the gap between the people who met your target population criteria, that's your high-risk population, and what we actually, did we serve? What percentage of that target population did we serve? When you start to do this, it is always so eye-opening to realize, oh my gosh, we are at 30%, we are at 40%, we are at 50%. And just as this is a real program graph from a real team I worked with, and what you'll see is this team plateaued at about 50% for 6 months. That's the middle part of this graph. They plateaued at about 50% for 6 months, and that's when we realized we can't just work harder, we have to innovate. So you know this who are change management experts and process improvement experts. Sometimes you can't work harder to get to your goal. Sometimes you actually have to change how you're doing what you're doing in order to get breakthrough results. And I've seen it, with my own experience. This is what it takes to get results, and it's not necessarily more money. It's really, really good program management and process improvement management. The middle bar, just to round this out, was about my little quip there that trying doesn't count in readmissions. And so when you're tracking something like post-discharge calls, we don't track how many patients did we try to make 3 phone calls and then give up. It's how many phone calls did we actually get somebody to pick up. And in this program, we learned, we were focusing on not just Medicare, but all adults, adult non-OB readmissions. And what we learned was the telephone is not our friend, and it's certainly not our only tool. A lot of people don't answer the phone. I'll tell you what, if you call me, I'm probably not answering the phone either. I mean, if I get a call from North Carolina, I'll answer because you're my friend. But if I don't know you, I'm not answering. And so most of us in America are like that these days. And so what we've learned is if we want to get the job done, we've got to innovate our methods. And that might be that we, of course, with an elder, we're not just calling the elder, but we might be calling the daughter, or we might be calling the personal care attendant. Or the patient we might measure completion of a post-discharge call if the patient went to sniff and we called the sniff and did the post-discharge call, with the sniff as in the circle back technique. So too with the younger adults, anyone who's under 65 these days might prefer a text or an email. And so what we did in this program, again, this is real data, is we said an outbound text doesn't count or an outbound email doesn't count. But what we do in that outbound message is say, hi, this is Amy from the hospital, calling to make sure everything's okay. Could you call me back, please, just to confirm that that you're doing fine. And so that gets our outbound message to be closed loop, definitively completed, and then we can count that as completed contact. So these are the features, I would say, of the execution of whatever it is that you're doing. Take the management and the implementation tracking to the next level to say, you know what, we might not have enough resources. We might feel relatively under-resourced. We might wish we had more people to help us, but we're going to manage and measure and improve upon what it is that we are doing with the resources we already do have. So quick review of some of the lessons, some of the videos that we reviewed, and I encourage you to watch them. And if you were with us and you watched them, now you have the links so that you can show them to your teams. And these are all freely available, and I find them invaluable teaching tools. And again, it paints a picture of success comes in a variety of formats and a variety of ways. And so, again, hopefully what you get from the Aspire method is the Aspire method are concepts and principles and methods but it is not a protocol or a checklist or an exact recipe of what to do, because by applying the Aspire methodology, we can have 100 different snowflakes of their own individual successful programs, and that's what you're going to see in these videos. All of these videos applied the Aspire method, and they got results, and yet they appear to be their own unique special case success stories. So success story number one was from a community hospital out in the Bay Area of California, and key elements of having worked through the Aspire method at that point, the executives and the leaders of this readmission committee said, we learned it's not about the medical, it really is about the social. That we needed a key skill that they emphasized was actually doing teach back, which allowed the teacher, or the nurse in this case, to assess and reassess and repeat and clarify, and how important the interactive back and forth teaching and clarification and restating and confirming is in the teaching process. And again, you know that, but are we, are we consistently doing that? They say that there's really success came from a high touch model, being in close contact with our patients, executing, yes, follow-up calls, but really emphasizing the importance of that post-discharge home visit. Again, for any of you who can do that, do it. That is the most important thing. And then those two things, the calls and the visits, allow for the arrangement and follow through on the appointments. What they did was they learned that a joint home visit between a nurse and a social worker was very high leverage, and it was a great use of time as well, because each professional was looking at items from their own perspective and came up with a much richer set of recommendations and supports for the patient. And I have heard this from coast to coast and everywhere in between. Again, if you have the opportunity to test that, do test it. They had a portfolio of strategies which didn't just focus on transitional care, follow-up visits, home visits, and appointment making, but rather also they had a strategy, as many of you do, for collaborating with the skilled nursing facilities. And what they did was they case conferenced. They reviewed patients at the end of the week who left the hospital and went to the SNF. What's their status? What's going on? Is there anything we need to clarify? And in that way, they had a very collaborative relationship with the SNFs in their kind of network, if you will. And it was built on trust and mutual respect. And again, I know you're doing a lot of this yourself, but that's very, very different relationship than expecting the SNFs to reduce readmissions and report back to you on their progress, right? They emphasize at the end of their video, we now have a lot of players at the table. It's not just about home health and SNF. They showed a video of their readmission committee meeting, 25 people around a table, and that most of the people are from beyond the walls of the hospital and very interdisciplinary in nature. And they rounded out by saying, success in this work is all about building out relationships. And that's better relationships with our patients through engaging based on their priorities, engaging in teach back and those engagement strategies, plus relationships with each other, because reducing readmissions is a co-produced outcome, and we need to be much more collaborative and interactive. So the next lesson from success was a very nice, I'll just call it crisp and straightforward, short video of Mrs. Ann McDonald, who is a retiree in Arizona. And Mrs. McDonald did not think that she needed any help. She has what she needs, thank you very much. But she realized that when she got home, she was quite overwhelmed with the nose sprays and the medications and what she was supposed to do when, because she realized that in the hospital, it was only once she was home that she realized that in the hospital, the nurse had been doing it all for her. And she thought she was tracking along and following everything. But again, when she got home and was alone and was out of the context of the supportive hospital, she was overwhelmed. So that was a light bulb moment. And I really think that there's a lot of valid truth and insight to saying sometimes we offer transitional care to Mrs. McDonald while she's in the hospital. But you know what? Sometimes we've got to let Mrs. McDonald get home and realize, oh, I could use some help. Oh, I didn't realize that I actually don't totally understand everything. And in this case, it happens to be that on the post-discharge call, she was again offered to have the transitional care nurse come out. And it was at that point that she realized, yes, I should say yes to that. So the transitional care nurse, in this case called the coach, came twice to her house. And in her words, I was not rushed. She explained everything to me. And best of all, it was free. And it kind of, again, gives you insight into how to engage with our patients. Whereas this Mrs. McDonald, at first she said no, right? And many of us in rounds would have said, Mrs. McDonald has declined transitional care. And we would shake our heads and say, you know, if you will, bad on Mrs. McDonald. But we needed to give it a second try. And then you can see what mattered to her was that she was not rushed and it was free. The third video is a multi-visit patient, and this is a profoundly moving video for me, and I hope you all feel the same way. This is a deeply, deeply troubled and sad story of a man, you know, whose life fell apart and had a lot of chaos and loss and loneliness and despair. And it reminds us that when we meet people who are in the throes of homelessness and addiction, they are actually hopeless. And I can't say this enough to just remind myself enough about what that must be like. And they are hopeless. And he says in his own words, talk about lonely. What he was doing in what we would call non-compliant, chaotic lifestyle, what he was doing was all he knew is he was lonely and he was lost in this world. And he says, as you can see on the slide, I didn't know how to deal with the hurt. I didn't know which way to turn. And that is where people are, a lot, especially of our multi-visit patients. And so remembering that there is a very desperate and lonely human, and remembering to not just call that non-compliant, not non-adherent or difficult, or certainly we're not going to call these people unimpactable. What happened was they had a recovery coach, not a doctor, not an advanced nurse, you know, a recovery coach, somebody with lived experience, as you probably know, probably could have also been a community health worker or a great social worker or a great community health nurse, you know, but a recovery coach said to this gentleman, we're going to keep coming back. And the gentleman had even said, Mr. Eisen said, don't come back, don't bother with me, I'm hopeless. And what this team did that's so impressive is they simply said, you know what, you're not hopeless, we're going to keep checking on you. And as long as you're still here, we're going to keep checking on you. And that is what broke through to forming that helpful, trusting relationship that now has gotten him into sober housing and a stable living environment. And he's got all the medical care that he needs. And now he says to us in the second part of the video, now today I have a plethora of choices, he says. And he says that he feels connected to his care team because he thinks that they're going to be proud of him. You know, he goes through time and he's been sober and he's doing okay, and he doesn't have family anymore in this world. And so he thinks of the care team as something like a family in the sense that they know his journey and they'd be proud of him. And it reminds us of really the calling and the mission of what the best of nursing, medicine, social work, and outreach work can be, and really what multi-visit patients need. So I'd encourage you to watch that video. And then the final video we shared was about Circle Back. And Circle Back, as I told my friends in North Carolina when I was at Atrium and then at the workshop with the NCHA, that I learned Circle Back from you. in North Carolina, and I've subsequently taken it across the country. And I would really want you all to watch this video because it's now we're going to call it a North Carolina grown idea that has now gone viral across the country. And this happened to be a team, a transitional care nurse in Virginia, who heard a conference that where I talked about this, and she decided to try it out herself. And it's a warm follow-up phone call conversation. It makes all the sense in the world. It provides the professional from the hospital and the professional from the skilled nursing facility to have that, clarifying conversation. Oh, okay. Let me check, let me clarify. Is it Lasix 20? Is it Lasix 40? I'll go back and ask and I'll get back to you. And you know what? Sometimes you just can't do that through the EMR. Sometimes the best, most effective and efficient way to clarify things is just to have a person, a colleague that you can pick up the phone and make those clarifications in real time. So I would really encourage you to look at that video. So in summary, hospitals that are getting hospital-wide results, all-cause readmission reduction, which many of you have that as your goal. They know their data. They analyze, track, trend, display, share, post. It is not secret. It is not sensitive. It is the tool against which they demonstrate their continuous improvement. They take a broad concept of readmission risk. They're looking at whole person needs, not just medical. They adopt a multifaceted strategy, as you can infer from video number 1. There's what are we doing in the hospital? What are we doing to actively collaborate across the continuum? And what services are we delivering to our highest risk patients once they leave? And those services are high touch, in person, and iterative over time. And increasingly, we're using technology to make managing and tracking this work better and quicker and more automated. How can we flag? How can we implement, track our implementation and our outcomes? So these are run charts from real teams across the country that have implemented the Aspire method, that have taken this approach to closing the gap between the target population who comes through the house and the target population that we actually serve. We track on actual service delivery, not attempts, and we try at every turn to optimize how much service our existing efforts can deliver to our target population without waiting and hoping for future resources to come. So whether it's ED high utilizers or inpatient MVPs or high risk of readmission at a small hospital or a large community hospital, success can come in a variety of ways, but success most certainly is possible. And I know that that you can get success when especially we attend to the execution of whatever it is that that you have already decided you want to do for your patients. So so coming out of the workshop, the participants in the workshop said that some of the high impact improvement ideas that they got from the workshop last month was that they thought that they ought to go back and broaden their definition and their concept of high risk. If we're trying to reduce all cause readmissions, then we need to go broader than the quote Medicare penalty diagnoses. And that is true every day of the week. So if you want to reduce all cause readmissions, then you're going to need to look at your data and say, what's driving the most readmissions at our hospital? Some other teams say, you know what, good point. We should identify all SNF patients as high risk. No further stratification. Again, this is based on data. If you're being discharged to a skilled nursing facility, your readmission rate is about 25% higher than anyone being discharged to home. And so this is actually, when at first blush, it seems counterintuitive, but when you think about it a little bit more, it makes sense. These are people with ongoing skilled care needs. They have ongoing physical debility. They need rehab. They need skilled care. So of course they're higher risk. And so focusing on that higher risk population can be a high leverage strategy for reducing all cause readmissions to the hospital. Other teams said they really liked the idea of understanding root causes of readmissions based on talking to the patients and the patient's families. And that's what we call the readmission interview, and that's in the Aspire guide as well. And then some other teams really liked the concept of segmenting our high-risk patients. Not all high-risk patients need the same thing. And some high-risk patients are multi-visit patients, and they need us to do things like Mr. Eisen needed us to do. And other high-risk patients are going to a SNF, and they need us to basically do a circle back phone call and maybe a case conference when they're transitioning from SNF to home. But other high-risk patients are more like Mrs. McDonald, and a 2-visit transitional care encounter is going to be exactly what that type of a patient needs. So segmenting out what do the different subgroups of your high-risk population need, and then managing to that. And then other teams said it really made sense to them to extend transitional care services into the home environment. And, I can't agree with that enough if you can at all possibly do that. So I think it's informative to look at just some of the 7-day kind of, if you will, these are things that teams said that they could go right away and do in the next week coming out of the workshop, and then what would they want to work on over the next month. And I would encourage you to think about this coming out of today's final webinar. Is teams say, let's go back and look at our data. Let's update our readmission, basically our plan, our analysis of who's high risk, what are the root causes, and what are our interventions. That's kind of that lean A3 planning document. Some said, you know what, we can go ahead and ask our patient volunteers to talk to our readmitted patients, and we're sure that they can get some good information that we can benefit from. So they were going to go test that idea. And then another team was going to look into where they could post an ED care plan for their highest risk patients, so that the next time the patient comes to the emergency room, because they're coming back, we can feed forward the high risk intervention plan or that need to know information to that next ED provider. And so then you can see what some of the other ideas were in terms of sharing the results of a data analysis. Then naturally, once we figure out where we post ED care plans, let's start to draft them on our high-risk patients or our multi-visit patients who come through the door this week and next week and as the month goes on. And then what are we going to do, and how can we build out effective patient pathways for the different subgroups of our high-risk patient population. So since I didn't see any chat in the chat box, I'm not going to leave any time for discussion. I took up our time for discussion. So what I'd like to just leave you with as we wrap this up and I send you off into 2019 to ever improve on your readmission work were some tools and templates that we shared at the working session that some teams really liked. So number one is, what are you doing? What are you doing to reduce readmissions, or even better said, improve the transitional care process? How do you identify your high-risk patients? Who's notified about that? How do you figure out what they need? How do you link your patients to what they need? And how are you delivering service and managing their care once they leave? And really pulling this apart in a disciplined way, simple, but disciplined, to not just say, oh, we have a post-discharge follow-up phone call program, but fill in the detail, pull out the operational detail in something like this type of a template, and it will show you the strengths and maybe some weaknesses of whatever program it is that you're trying to implement. And then, as I've emphasized throughout this hour, measure whatever it is you're implementing, measure how many people were in your target population, how many discharges were in your target population this month, what percentage of those discharges did you, quote, serve in whatever way, shape, or form, whatever your plan was, did you serve them while they were here, and did you serve them once they left? Whatever served means, again, for you, if that means a warm handoff, or a post-discharge call or a family meeting, whatever your transitional care readmission reduction intervention is, that's what you define as served. And you just purely focus on increasing the percent of patients in your target population that receive what you had already decided you wanted them to receive. And that is really worthwhile work. Finally, a lot of teams I noticed are not trending their readmission rates for the target population. There's a lot of reporting at the hospital level, hospitalized all-cause readmissions. If you are working on high-risk JVON or sepsis or whatever other target population group, you need the red line in addition to the blue line. And it's the red line where you're focusing your efforts. So this is, again, real data. This is, for example, sepsis readmissions and in the red line. And we're going to drive down sepsis readmissions, and you're going to see success on reducing sepsis readmissions. But reducing readmissions for one target population is not going to have an impact on hospital-wide readmissions. You can just do the math yourself, but mathematically that's impossible. And so so I want you to see and have visibility into the impact you're having for your target population, and not let that success signal be blunted or hidden in the fact that all you're looking at is the blue line, which is hospital-wide all-cause readmissions. So definitely measure target population and hospital-wide as you move forward. So I know we've come up to the top of our time. Thank you so much for coming today. Happy holiday season to you all. Thank you for your commitment to reducing readmissions. I hope you know that success is possible, and I hope these ideas have given some food for thought as you move into your next phase of readmission reduction work. It's been a true pleasure to work with Trish and Sarah and the team at the NCHA Knockout Pneumonia campaign. And with that, I'll turn it over to Trish to dismiss us from the webinar. Trish?
Thank you, Dr. Boutwell. And also thank you to our members and participants on the line. Thank you for taking this journey with us over the past 8 months or so as we have been aspiring to reduce and knock out pneumonia readmissions. For those who are looking for additional resources, you can check out our NCHA website. Under the foundation, you'll see a tab that says Clinical Initiatives, and that's where you'll find our pneumonia work. Under that, you'll see a tab that says Aspire Series, and it will have a record the slides from all 8 webinars that Dr. Boutwell provided, as well as our playbook and resources from the in-person session in November. Feel free to reach out to myself. This is again Trish with any questions that you may have as you start to begin your work for 2019. And again, one last thank you to Dr. Boutwell. We have enjoyed this series and working with you over the past several months. All right.
Thank you.
Thank you, everyone. And this is all for today's session. Bye.